residents, residents going through the same training as I received. I have a lot to go over, so I'm just going to go ahead and get started. When I was a resident at UCSF, I never attended a lecture called Global Health Software Design. And so I would say that one of my hidden objectives here is for a few residents in the audience to maybe plant the seed that this is something that they themselves could do. This is a very challenging but extremely rewarding path. Because I now work in global health software, I have the privilege of really seeing a lot of the cutting edge work in digital health and in mobile technologies. And when people share those projects, almost by necessity, they follow a very specific pattern, the lectures. We made a tool, we tested it, and here's what happened. But I'm extremely lucky because my colleague in Uganda, Dr. Mary Muhindo, will be presenting next week about our software's real world use in Uganda. And what that does is frees me up with a lot of time to go into some of the deeper issues around software design that we think about every day at Global Strategies. I like that whenever I'm looking at a new software project, whether it is our own or whether we're being asked to look at someone else's or participating in the design of someone else's software, there are two questions that I always ask myself. Why? Why did you make that software and not something else? Why did you choose to do it in the exact way that you did it? This is the world of software design. I was inspired to do this work from, as Sohail mentioned, the year I spent in the Eastern Congo in the city of Goma, where this photo was taken. Aside from the diaper couture, this actually could be San Francisco, maybe without missing the cardiac leads, but it's a well-appearing preterm baby getting CPAP in the city of Goma. But this is the exception. Goma and San Francisco have almost nothing in common when it comes to newborn care. This setting in the Eastern Congo has one of the highest neonatal mortality rates in the world. And when I was living there, it was as high as 1 in 20 all babies. It's extremely difficult to get specialized pediatric training. So I was one of 2 pediatricians in a city of 800,000 people. And when people hear that, they imagine sort of the world's worst and longest waiting room. But of course, that's not true either. The reality is that dedicated Congolese healthcare professionals are providing care for babies all around the province, including in the city of Goma. After living there for a year and plus, it was quite clear to me that we weren't going to snap our fingers and make more pediatricians. And if we could snap our fingers and make anybody, it would have been a neonatal nurse anyway. What we needed to do was to help people who were already caring for babies as part of their job do that work better. And we set out to achieve that goal by making a software. This software was going to help people, make it easier for them to follow newborn care guidelines. So fill in those gaps that they didn't get in specialized neonatal training. We called that software NoviGuide, simply meaning new guide. I'll tell you that we did not spend a lot of time thinking about achieving the same aim through a paper intervention. And that was for a reason, a simple reason. We didn't think people liked paper, and we wanted the medium to entice users. We wanted them to want to use it. If the medium was the message, what message was a piece of paper sending? If you're in residency right now and your residency director hands you a piece of paper and tells you to fill that paper out, you don't need a focus group to know what the message is. That message is loud and clear. This is work. And we wanted to avoid that at all costs and make this seem like it wasn't work. This was something different from work. I want to go through 3 design decision points that we came up against, tell you about what we had to decide, and then show you the real world impact of that decision. The first was related to the medical content. Okay, we were going to make a software application that helped people initially follow neonatal guidelines. How deep were we going to go? I put this icon of a diver having just watched the Olympics and trying to explain to my 5-year-old this concept of degree of difficulty. Degree of difficulty was something that the diver had to decide in advance. And just like the diver, there was high risk, high reward calculus. The more difficult you attempted, maybe the higher the score, but also the greater the risk of failure. We ultimately chose high difficulty. And I want to show you what that looks like and the consequences, both positive and negative. You have to bear with me because I have quite a bit of zooming, advanced zooming. This is the NoviGuide as you might find it today in Eastern Uganda. This is an application that is held by nurse midwives. Let me just put a case, show you a case so you can get a sense of what I mean by high degree of difficulty. Okay, here I've entered in that I want to put in a new patient, and this is just me filming myself putting this in. I start to enter in that the baby's preterm, that this is a danger sign, that the baby is real. We can talk about that, why you have to indicate that. 1.74 kilos, so small, sick appearing and having difficulty breathing. So immediately we're actually in the #1 cause of child mortality in the world. Next, one of the advantages of digital, obviously, is that you can open and close lines of questioning in response to danger signs. So by indicating the baby's preterm, we now need to know more about the gestational age. I just paused here to say that we're always looking for places to make the nurse's life easier. So, if you knew the last menstrual period, which is not always known, you could find the corresponding gestational age in weeks tied to the device date. I filmed this back on August 23rd. From here into the temperature, I put the baby is cold because that's just very likely in this scenario, normal heart rate, and elevated respirations. From here, the NoviGuide now asks to check the oxygen. And if we were all together and not on Zoom where everyone is muted, someone would interrupt me before I even got here saying, well, wait a minute, I've been to these settings and they can't measure the oxygen saturation commonly. And that is true. One of the things that made this degree of difficulty hard is if you don't have an oxygen saturation monitor, you will actually never see this page. The page pops up in relation to what each site has on hand. And this was one of the things that really ramped up the degree of difficulty far beyond even what we had thought when we started. So that if you don't have it, you will be directed straight to treating the respiratory distress. Similarly, on the next page, as you treat the baby's respiratory distress, you are seeing options that you have told the NoviGuide that you have. So if you had CPAP here, you would see that. And this keeps going. What makes the NoviGuide in part unique is it's tying together multiple parts of the neonatal assessment. Let's pause here at glucose. If you're a resident on this call, you would have had management of newborn glucose as part of your intern core lecture series. But what about people who never got that lecture? Well, what are the things you need to know? You need to know whose glucose should be checked. And the NoviGuide kind of knows that based on what you've already told it. You told the NoviGuide the baby was preterm. That would automatically get the glucose checked, sick appearing, small. But then it helps you interpret the level. I should just add back in as a reminder, only if you have a glucometer. And here I put in that the glucose is very low, confirm the weight, and get the contextual drug dosing back. So we were trying to give as much as we could back to the nurses who were using this. If you were a group of Ugandan midwives attending a session being trained by Ugandan midwife trainers, people would pause here a bit to take in the view because this is something that people are hungry for. This automated calculations, things people are doing by hand or plugging into a cell phone, but needing to still have memorized the equation to put into that cell phone. I'll let this keep going now into infection, one of the top causes of neonatal mortality. Obviously, the sick preterm baby would be getting antibiotics, confirm the ampicillin and gentamicin, same as at UCSF, but then taking the time to go into the vial sizes so that you can give both the dose in milligrams, the mixing instructions, the ultimate dose in milliliters, which is what nurses need, and the administration instructions. I'll say preview upcoming attractions down here with the stock levels. And this plays out. And what, for those of you who are pediatric trained, what you can see is it's also helping you do this in a systematic way. You should deal with glucose before worrying about HIV. You should deal with vital signs first. At the end, we're going to say this baby is not well enough to feed on day of life 0. And the NoviGuide now has to remember, these are the consequences of tying these together. the NoviGuide has to remember, well, wait a minute, we calculated IV fluids in this baby way back when we dealt with the glucose. We have to remember that when you tell us the baby can't eat. I want to show the summary page because I think sometimes in global health, we have this idea that we go to these sites that have poor healthcare. We're trying to get them closer to maybe something that matches our own training. But there are many problems with our own system that we can sometimes innovate or fix in a totally different context. I showed this one because this was something that I found frustrating with our own medical records, that here we are typing all day into the medical record, and then we have to separately type out a problem list. Doesn't the computer know that we are dealing with a preterm baby by now, as we've entered that into it hundreds of times? Here, the problem list is auto-populated. This is like, something that I wish we had in our own settings, which now is available in Eastern Uganda. I'll just zoom forward to show you that in addition to initial assessments, we also have newborn feeding logic, which was one of the most complicated areas of NoviGuide that we have dealt with. This is me on a separate baby starting feeds, maybe day 2 or 3, the next day on a preterm baby, confirming the birth weight as 1.85 kilos, the gestation of 32 weeks. And once you confirm the weight, getting out not only the total fluid calculations based on your guidelines, but also the feeding calculation rounded to the nearest milliliter, and then the corresponding IV fluid calculation to get you here. This is the day-to-day work of pediatric residents. Why did we do this? I'll pause the screen share to say, why did we attempt this degree of difficulty when we could have done an alternative? An alternative might have been to start with something simpler, like sick babies should get antibiotics according to your guidelines, or treat all babies with respiratory distress promptly. There were 3 reasons why we didn't do that, and a 4th that could have been a reason, though we did not know it at the time. The first reason we did not do that is our understanding of the problem. This is critical. It's like we had worked in Goma for years. We had delivered this type of clinical medicine ourselves in our profession, and we just didn't believe that that would be enough. We didn't believe it'd be enough to say sick babies should get antibiotics. And having worked with the NoviGuide for years now, I actually don't think it'd be enough to say sick babies should get ampicillin and gentamicin, or even that they should get 3 milligrams per kilogram. I now believe you need to take it all the way down to the milliliters. The second, and you could probably see this from the attention on the colors and the user interfaces, we were not just going for nurses using NoviGuide. Our goal was nurses would love NoviGuide, that they would come home and tell another nurse, guess what I saw at work today. Software just permeates our lives in 2021. We're talking through software now. And yet we all have these examples we can remember where software just like got it right. Maybe an example, just my last week, I was like driving in my car and the GPS tells me, take a left turn, get in the second lane from the left and take a left turn. That prevented me from then having to cross over in the subsequent turn. And it's like, yes, I love that. That is great. That just makes me feel great that this software got it, what I was trying to do. So too in Uganda. As Dr. Muhindo will share with you, one of the questions she asks people is NoviGuide asking you the questions you're asking in your own mind? The third was the data. We knew that if we could do a lot for these midwives, they could give back a lot in the data. If we could help them calculate the gentamicin, they could tell us when they were out of it. This was like a critical piece of this. The 4th thing we did not know at the time, but I can share with you now, and this was mostly learning the hard way or learning through failing. We did not start with an easy algorithm. We didn't start with an easy algorithm because of the problem we were trying to solve. We were trying to work on neonatal mortality. These were not simple algorithms. I'll give you an example of a simple algorithm: standard prenatal care. Why is that simple? It's simple in the digital world because most every person gets everything. There are no contraindications to prenatal care. There are very few contraindications to the standard things like prenatal vitamins or testing for HIV. But when you work with simple algorithms, you're not prepared for the larger ones that are lurking. To give you maybe a metaphor, if you were trying to move from one house to the other, but all you had to move was standard size cardboard boxes that each weighed 15 pounds, you could get by just picking up the box and moving it into a truck. When you are moving pianos downstairs, you don't only need more people, you need more tools. You need tools that are designed to handle these bulky and unwieldy algorithms. And that is something we learned by working with them. I'm going to switch back over to the presentation. One sec. Okay, this decision to go for high complexity, high degree of difficulty algorithms had an immediate consequence. And that was a consequence that would lead to multiple years of work. What was that consequence? Let me take you through another simple algorithm, something that you may be familiar with if you're pediatricians, which is Billy Tool. For those of you who don't know what Billy Tool is, this is an application put out by Stanford originally that asks you two questions. How old is the baby? And what is the level of jaundice as a blood test? It takes those two questions and gives you back kind of like a green light, yellow light, red light. Green, not that much jaundice. Yellow, medium. Red, high risk. That's a simple algorithm. How are those made? Well, imagine you were trying to make that. How did they make it? They wrote out instructions and gave those instructions to a software developer. That software developer then goes and makes it and gives it back to the doctors. The doctor then plays with that software to determine if the recipe was followed correctly. And I would say something I learned, maybe the hard way, over multiple years is that works just fine for simple recipes only. That only works for things like peanut butter and jelly sandwich, where if I tell my daughter to make one and I taste it, I can tell if she forgot the jelly. That does not work for eggplant parmesan, where there are multiple steps and there are multiple things that could go wrong. There's no way someone could taste an eggplant parmesan and say, you got it exactly as I followed it, as I wrote it. We couldn't do taste tests. We needed an open kitchen. This was like a key learning point. We needed an open kitchen where the software developers could be watched by doctors, watched by visiting doctors, visiting nurses, visiting pharmacists, all staring at how the software developer was making the recipe. Let me show you what that looks like. When we first started with NoviGuide, we used to call the tablet the NoviGuide. But today, this is what we would call the NoviGuide. The NoviGuide became a platform for taking any clinical algorithm and working on it in a transparent way to generate end user applications. Let me show you its key features. The first is that the decision tree is transparent. So this is the one we just went through. This is the neonatal one that a nurse can fly through in under 2 minutes. Every single question that the NoviGuide asks you is here, and you can see how the NoviGuide is going to respond to everything you tell it. If you tell this is probably small on your screens, but if you tell NoviGuide this baby's preterm, this will tell you this is a danger sign and this baby requires close attention. But also how the data is collected is transparent so that this is going to record as prematurity. That's what's going to count as prematurity. But this includes even the complex logic. So gentamicin dosing in a WHO dosing scheme. This is how it's going to do it. It's going to say the recommended dose is this. If the baby's less than 2.5 kilos, give 3 milligrams per kilogram. And this is how it's going to interpret the mixing instructions. But even further, we knew we wanted to configure to sites and to site-specific equipment. So if you look here, this is the one we just went through, but what if you couldn't check the glucose? Whole parts of the logic go away, and you're filtered into asking about symptoms of hypoglycemia instead of checking the glucose because you can't. In addition, things like, well, we're using WHO dosing. What if someone used like the UCSF dosing, which is largely based on package inserts or lexicon? We have that dosing built in, and we could even configure to certain other aspects of this. I think when people ask, one of the questions people ask is, why did nobody do this before? This is really the answer why nobody did this before. It's just the labor of love. And, this came from, being in Goma and seeing so much suffering and thinking what could possibly start to turn the tide in a scalable way. Okay, I'm going to switch back over again. Pardon the Zoom dizziness. Okay, these are parts I don't think I've ever showed anybody in the United States on the back end of some of this. So I'm excited to share this next part with you. We now had an application that we thought was configurable actually to any national guideline in sub-Saharan Africa. And one thing I didn't mention, but it's probably obvious from looking at the algorithm itself, is that NoviGuide is not experts in Ugandan guidelines. Ugandans are experts in Ugandan guidelines. So what the platform allowed you to do was to work with Ugandans to see, did this match exactly what you wanted it to do? The NoviGuide is never creating medicine de novo. It's aligning always to a source. That's critical in its safety. We're not qualified to come up with the guidelines for Kenya or Rwanda. We have to work with in our case, pediatric associations to determine if we got it right. But having aligned it to Uganda and having traveled around, I felt quite confident. We probably had one that was ready to go. Rwanda, Tanzania, Kenya, Ghana, any of these sites that are deriving their guidelines from the source material at the WHO, and even a little bit beyond the WHO because we could configure. The next question became, how do we deploy this technology? Are we just gonna put it as others have on an app store where people could download it? We chose not to do that. And this was design decision number 2, which had major implications. I think there were so many different paths we could have taken. I think it's best to show you the path we did take and then kind of explain why we did it that way. This is a page that is only seen right now in Uganda, but it is one of the things that differentiates NoviGuide from really other software is trying to achieve the same aim. This is the access code. Let's say that I gave you a NoviGuide and we're trying to start NoviGuide at your facility. I'll give an example of our headquarters in Albany, California. If I wanted to start an Albany, California clinic, I would give the NoviGuide software, download it onto a mobile device and open it. And you would be asked to enter a code. That code might look like something like this, 123 ALB 123. Once you entered that NoviGuide is now tied to a site. It is tied to a site. And I want to show you what that means by showing you a little bit about in the back end. Okay, let's imagine that we just put in our code and we are using the NoviGuide. This looks exactly like what I showed you, where nurses are putting in. But I'm now going to focus on this red button up here, which is administration. We knew, having had this tool and tested it in Uganda and South Africa, that we needed ways for almost all of it to be done locally in Uganda or in Rwanda, wherever the team was. Those teams needed to be able to add and subtract users by themselves. Those teams needed to be able to configure and adjust equipment by themselves. And they needed to do it in a way that was easy so that you didn't need a special tech training to add users, delete users. If we go into administration, you can see to add users is simple. These are the users at our site in Albany, California. But if I wanted to add users, it's as simple as clicking add user, typing in the name. And in Uganda, people like to use the birth year as their 4-digit code to get into the NoviGuide. So I can add in 3 doctors or 3 nurses quickly. We're talking about setting up a site completely in 10 minutes, especially if you're online. We can talk about the online, offline parts of this if there are questions later. But let's say I add in Jack, Michaela, and Sohail into the NoviGuide. it's this fast so that you could do this. And you can also support sites remotely. So if a group in Kigali needs to support a rural site, they could simply log in, add that person's users, and help out remotely. You can also delete users. This came from our field experience. Staff turnover in these places is intense. I would say on average, just the number in the back of your head from our experiences would be 30% staff turnover every 3 to 6 months. So this is a dynamic registry of people using the NoviGuide. I'll pause here at equipment. Adjusting your equipment and therefore adjusting the decision support you see is also quick. This is just drag the equipment you have into a new place, and all of a sudden, NoviGuide thinks you have a glucometer. But there was more to this. Let's say a device needs to switch locations to a completely different clinic with completely different personnel. It's just a matter of changing the code. So if we change a code on our end, all of a sudden, I'm in a Spanish-speaking clinic that's configured to Spanish. I'm the only user there, and I have equipment that looks completely different than the site in Albany. I can go back and forth. This allowed us to not have devices that were stuck in a specific clinic. This also has some of the gamification. Why did we make this decision to do it in this way when we could have done it in another way by putting it online and just having people download it? And you can imagine, had I put it online and had people download it, actually there are residents on this call who probably would have downloaded it and would have maybe used it. And we would have gotten data back that looked like, X number of hundreds of thousands of downloads, X number of uses, but that would be the extent to which we would have the data. Why did we do it in this way? This goes back to the problem we thought we were trying to solve and how we understood that problem. And that was maybe one of the key messages I would give to the trainees here is it was about defining the problem. How did we understand the problem of scaling newborn care in a setting like Goma? Did we believe it was an individual pursuit, meaning that that all we needed to do was get Josh Bress to be better and that would lift everybody? We just did not believe that. We did not believe that delivering newborn care is an individual pursuit because everybody knows that it isn't. Everybody knows, if anything, neonatal care is a team endeavor, and the fields that team plays on are hospitals. We needed the design to match our understanding of the problem, even if it led to all this extra work to build in these functionalities. Relatedly, the data. If what data was going to be useful, it was team data, not individual data. If Josh Bress is winning and the team is losing, the team is losing. And we needed data that we could link to teams. This back end stuff had real world implications, which I'll show you here. Okay. Well, let me see if I did this right. Okay. This is fake data, but I made it in preparation for this talk because I think sometimes people talk about data is being collected. And if you're a clinician in the real world, you're like, I don't see this and I don't see it impacting me. And how does this help anybody? I made this video to show how these pieces fit together, how by having NoviGuide tied to sites, all of a sudden the data was tied to sites. What you're looking at here is a site-specific dashboard of a fake clinic that I just made for this talk. And I called the clinic District Hospital. So it has an unusual pattern because I just made it and started playing with it. But let me show you the key features of it. The first is obviously the name, and you can see how people are using the NoviGuide and the level of engagement. And I will just say that in Uganda now, every single site we work with has this for their own individual site. You can see the users and the level of engagement. You can see insights, the type of babies they're putting in, and the inventory. And if you look at the inventory here, it's like I'm saying, okay, all the drugs are looking good. All my equipment is looking good. Then what I did, just to show you how these pieces fit together, is I connected the NoviGuide to the computer, to the internet, and just started using it over here. I start saying, look, my phototherapy is broken, my oxygen concentrator is broken, and then I go and enter in a new case. And you don't have to follow this. I'll just tell you what the case is. It's the case of a term baby who is well appearing, but whose mother has a fever and whose mother had prolonged rupture of membranes, meaning that the water was broken for more than 18 hours. In the Ugandan national guidelines, because of the risk of infection, that would be antibiotics for the baby until the baby's proven to be okay. If you're watching quickly, you'll notice that, yeah, every trip through the NoviGuide is slightly different. Here we are at the risk factors, membranes ruptured and fever. I'm going to say we're going to give antibiotics, just like the guidelines would instruct. Pick the vial size, confirm the weight. But here, I'm going to indicate that I'm out of those medications. And you may say, well, why would someone calculate a medication they are out of? It happens all the time. And the reason it happens is because in the real world, people may not have it at the hospital, but there's a private pharmacy that has it. And they're going to send the father or the sister to go and purchase that medication and bring it back. So it's not quite as clear cut as have medication or don't. There's like, don't have it on site, but have it locally or don't have it at all. People calculate medications they don't have every single day in the NoviGuide. Okay, we finished this assessment up. And this is admittedly connected online, but you could do this asynchronously and sync it when you're done. Once you get to the end, you can see there's also breastfeeding videos. There's things I don't have time to go over here. Once you get to the end, and you sync it, I was using this online and just doing this live. If you refresh the dashboard, now all of a sudden this case is already transferred over into actionable data at the district health office level. You can see that 38 went up to 39. And if I go down to the inventory, all the stockouts I just put in are reported live. Stockouts is just one example, though. There are many, many examples of the type of quality improvement data you can get from this. And this is why we tied it to sites, because all of a sudden the data had meaning. If it's an anonymous UCSF user, I don't know what to do with that data, aside to say people used it. Here, we're talking about real actionable data on how to use what you're dealing with. I'm going to pause this here. And since I have a second, I go to one last piece and then open it for questions. The last is because I have kind of I know there's pediatric residents here. I thought I'd show you something that maybe pique your interest because it's very close to home for you. At the end, with newborn care, we had actually stumbled into an area of clinical medicine that had a high degree of harmony, meaning, yeah, Uganda guidelines look like Rwanda guidelines, look like DRC guidelines in a different language. But what about topics that are inherently more variable? This is now getting into like futuristic applications of the NoviGuide, but I'll show you one. What do I mean by things that are inherently more variable? Let me give you an example from pediatrics, an asthma attack. Okay, a child has an asthma attack on a school field trip or in a doctor's office or in an emergency department. Could you design a single application that could handle all three scenarios? Okay, now we're getting into more complicated, high variability. Here's another example. A preterm baby is born in Gilroy, California, San Jose, California, Stanford University. Okay, where the disposition of that baby, where that baby ultimately goes, is highly variable, and it's based on what the site has on hand and their dispo patterns. You notice that dispo wasn't a big factor in our Ugandan protocols yet. Another way of thinking about high variability algorithms is there used to be like an old advertisement. There's an app for that. There's an app for that. What I've told our team is there's not an app for many, many, many things in medicine. And they are this category of thing that's like, here's another example, COVID rule out at UCSF. That's an institution specific protocol that's going to look nothing like COVID rule out in Salinas. So because of the people you're talking to, the orders you're putting in, that's very, very variable. We have done one example of this that I think gets at the potential of these tools I want to show you. And this is actually an area that for PEDS residents will ring some bells. One of the areas we have worked on based on our work, building off of our work in Uganda, was newborn glucose. And for those of you on the call who don't know about newborn glucose, if you went to Boston Children's Hospital Philadelphia, UCSF, and Stanford and said, show me how you're managing your baby's glucose, you would find 4 different protocols. This is highly variable. We set out to ask, could we build something that could account for all of those variations? Let me show you what that looks like on our end. First, here's the shape of the algorithm. And for those of you interested in this math side of it, it is amazing how many turn out to be diamonds. There's something we can talk about another time. Here, you can adjust every element. Every single element is configurable. So 0 to 4 hours, what's a normal glucose? Oh, at our site, we want it, above 40, and it would be low if it's between 25 and 40. And if it's less than 25, it's severely low. But maybe at another site, it's 35. You could just slide this and have it correspond in the decision support. In another area, you could say, look, who's even in the glucose protocol? Let me show you what this looks like. These are common reasons to get a baby's glucose checked in the United States. This is big, a rural America usage. Your mom is diabetic, you're large. These are the reasons a baby would get their glucose checked. But maybe some sites, as actually at our site, we include mothers who were on beta blockers. So you just click here and have it appear here. This is like live configuring to high variability pathways. Another example is here. Right now I've put in that the baby's mom is diabetic, and the guideline for this site is check the glucose every 1 to 2 hours of life, and then for every feed for 12 hours. But maybe Kaiser doesn't do it that way, or maybe rural health in Oklahoma doesn't do it that way. Maybe they like to check at 1, 4, and 7 hours. You just click from all possible configurations. The future of this is that at the beginning, we say, okay, show me your guideline and let's work together to come up with an app, software that aligns to your guideline. We are close now to saying, I could show up to UCSF residency room and say, show us that guideline. I think I already have it. And what that does is really changes the nature of quality improvement. So you can go from like boxes and arrows that are pasted on walls and not always applied to like point of care decision support very quickly and efficiently, so that there could be apps for things that people hadn't thought about. I'm just going to conclude by showing just one last comment, which is, and I put it on a slide, so I guess I can show you this as well. For residents interested in this type of work, or for pediatricians who are thinking about this type of work, I would say one of the take-home lessons I've learned is that the problem guides the design, and you are experts. You're experts in these problems. A UCSF resident will graduate and will be an expert in the management of asthma exacerbations, a whole host of problems. And there's a need for that. There's a need for people who really understand these problems in depth to help design software to address them. And this work really transcends from global audiences. All countries are having challenges following these guidelines. So I think I'll stop there and take any questions.
Thank you, Joshua. So there are some questions in the chat. A couple of our participants.
Let's see if I can see them. Should I just follow through these questions? Let's see.
Yeah, we can do that.
Okay, one question is about stock. And I would say that how does NoviGuide inform stock? What I would add to this, and this is something that I've seen in my own work, is it's another layer. It's just another data set. And it doesn't necessarily have to interfere with how you're already calculating stock. Let's say that someone says they're low on gentamicin. and they're going through the NoviGuide. What it does, well, the way I think of this in my mind is it's like sends a flare out saying someone should call this site and see if they truly are. What makes NoviGuide unique is that it allows that midnight nurse who maybe otherwise wouldn't have an opportunity to report that stock out to send that data. Another way to think of NoviGuide is a transaction. We're going to help you with all this content that you need help, and in return, you'll tell us where the stockouts are, you'll tell us where the gaps are. Different levels of care with NoviGuide. How do you work within different levels of care? I would say a lot of the care is guided by equipment. So what makes a site different is its availability. One way to think about sites is higher acuity sites are more specialized in specialized equipment. So a higher acuity site may have CPAP, or a lower acuity site does not. But this work is also done by local implementers. So when local implementers go out, they do a site assessment to figure out, okay, what does this site have, or what are they missing? Are there gaps? Are there gaps where you would expect to find something at a site that doesn't have it? Here's an example of a gap. Sites that have CPAP should be able to measure oxygen, but you find that sometimes they don't. Okay, people asked about applications outside of neonates and into pediatric illness and other areas. This is an area that, of course, we are exploring. And the reason we explored it was because we learned that the midwives are users, and they were sitting there with moms. And so we had like the audience already there to use maternal algorithms. One of the things that we are really advocates for is, I think this is the cheapest way to do this, even though it looks fancier from the end user side. And that's because of what's being alluded to. You can beam people new decision support pathways, just by passing them through. So once you know how to use the NoviGuide, if the Ugandan Obstetric Association and our team work together, we could be sending out the obstetric algorithms without any new devices, and without even a lot of training if people already know how to do this. Okay, what about settings where people have offline, online? Like all softwares that do this type of work, NoviGuide works offline. So you download it, and this is not unique to NoviGuide. All softwares in this space do the same approach. They work offline. You download them. You have to be online to download them. You download them. Then you can work offline, and when you sync up, you can then send the data back and get updates. I would say a big challenge. I've shown a lot of where the successes were, but I hope I gave the impression that this wasn't an easy road, and you learn a lot by stumbling. One of the challenges is, what if a group doesn't synchronize for a while? What if they need to synchronize to get an updated version? You need actually safety controls. It's one of the reasons we don't put it on the App Store. You need safety controls and to make sure that you're always using a current version. What kind of mobile devices does NoviGuide work on? It actually works on all devices, including web. So the NoviGuide algorithm shop flows into a tablet, phone, or web-based application. We have not, this is a design decision I guess I could have put in this talk, but we did not use personal phones for a number of different reasons. And I'm not saying we wouldn't never do that, but there's an advantage to using institutional devices. A lot of that is related to device control to make sure. The other is when you are studying NoviGuide, as Dr. Muhindo will share, you kind of need to make sure that if you're watching someone as part of a study, that you can distinguish between whether they're on their phone, looking at Facebook, or on the NoviGuide. And you need to be able to do that from across the room. Comments about patient safety. For sure in the United States, and increasingly as we learn more about medical errors abroad, it's like another way to think of this is as patient safety. I think one of the things that I would add in is parents. It's very easy to think of medical topics, but especially in neonatal care, the more we learn about how parents engage with this care, one of the things I wonder is could you make something that's like a neonatal rounding tool for parents so that parents can engage with the neonatal providers and ask questions? Again, the questions about online and offline. So I think I ran through the chat, unless I missed anybody in here. Oh yeah, someone's asking, could the NoviGuide be used as a training software? I will add in a little bit of that because it was already published by Dr. Muhindo, and I think she'll be talking about the current work. But one of the interesting things about NoviGuide is that question, are you using it on a real baby or not? We ask that question because it flows into the data. So you don't want like a bunch of practice cases in the data. But one of the things Dr. Muhindo showed is actually people never use it for practice once they know how to use it. They only use it for real cases. And a lot of this is in design. It's like nurses perceive the NoviGuide as like a work aid. They don't see it as extracurricular, learning outside. They don't necessarily even see it as CME. So one of the things I've learned, and I would say some of this is learned the hard way, is nurses decide what the device is. They decide what they're going to do with it. And they have decided that they use it as an aid in real world care delivery, and they don't use it for outside education and training. However, probably no surprise that nurses score much, much better on tests after using this. And the reason is they're just like going through the guidelines again and again and again, so that by the end of using NoviGuide, they could tell you the exact dosing. They could even tell you some of the mixing, but it doesn't prevent them from using it. I would say there's so much to learn from talking to nurses about these tools. And one of the things that is always funny, I would say, is wherever you are in the world, people use driving analogies with the NoviGuide. The NoviGuide keeps me on the road. It keeps me from driving off the road. If I bump into someone on the road, I know it wasn't because of something I did. And those driving analogies are how people understand it. It's like it's a GPS through the guidelines. Any other questions? I can also just take, if someone wants to unmute, I'm happy to take any question as well. I guess one thing I'll add is when you talk about a project which has now reached a certain level, you brush over the parts that were challenging or difficult. And I think some of the challenges in this area is one way that medical software is different than other software. Like in Silicon Valley, you like put out an app and you see if people like it and you get back feedback immediately. You really cannot do that in medical. It has to be a certain quality and safety before you would ever even try it, even in a demo or in a study. So that is a challenge. And then I would say another challenge that you encounter in this field is how people think this is ultimately going to be done. Are people going to be developing open source software that people just download and piece together themselves out of component parts? Or are we going to be developing really comprehensive, but more labor intensive in their design solutions? And for me, I think when we work with nurses, and I would say this extends even to work in the United States, we don't ask enough questions about what the nurse actually really wants the thing to do. And it's by following that nurse feedback that led to NoviGuide design the way it was. Another way to put this is when we go into the field, back when we traveled, now NoviGuide is rolled out remotely, I would tell our team, remember, you're not trying to figure out if the shoe worked, you're trying to figure out if the shoe fit. And there's a big difference between fit and work. And fit is like, I want to put on that shoe. That shoe is mine. It fits me perfectly, has my name on it, it's mine. That's just a whole different world of design where you're not just thinking purely function. In a way, some of the purely function stuff is tedious and it comes from source material. So it's less creative than the side of making things.
Thank you so much, Josh. I encourage folks to come off mute and feel free to ask questions directly. Maybe I'll kick one off in that vein. What do you think the tech solution here doesn't solve? like what are the additional components that you think are important in terms of a holistic package of improving newborn care?
Great question. Okay, for newborns, it's easy. Hands-on procedures and respectful care. Those are the two things that NoviGuide cannot do. And with the way I tell people is like NoviGuide should be like a fish that swims along with the whale shark. You know, you're going in to do helping babies breathe. You're teaching hands-on procedures. This is not going to do that. Leave this in place. Skip those lectures about antibiotic dosing. Spend all your time focused on bag mask ventilation. Respectful care can sometimes surprise people, but it shouldn't. The NoviGuide only works if the information that the mother in many cases gives is accurate. Okay, the only way that a mother would give you accurate information is if they trust you, that you're going to use that information to help that person. How do you determine a mother's HIV status? You need to know that for the NoviGuide, but you shouldn't just ask somebody, obviously. You need to do this in a respectful way. So the respectful care is what allows the inputs in a very like techie way of thinking about this work, which is so human and it's the real world. You need people to trust you, to give you this information, you know, what, and you also need to like get people to give you accurate information. Like when did your bag of water break? Okay, we need to go back in time. You know, how many, if someone says, I don't know, it's like, no, we need to know. So we need to talk. The respectful care is huge. Outside of the hands-on procedures, and neonatal has a lot. So there are whole areas that like don't need the hands-on procedure part. Those are the two. You can imagine like breastfeeding, kangaroo care, like everything that involves hands. We have videos in there, but that's a poor substitute.
That's a great point. Pausing to see if other folks have questions. Maybe if I can ask, looking through the chat, Goldie, I noticed you had said that you're trying to get buy-in from other countries for this type of work. I'm curious, you know, this perspective of you or other folks in your shoes who are see the utility in these types of solutions. What tend to be the issues in terms of achieving buy-in or getting folks to be interested in engaging?
Hi, and thank you for that. And Josh has had various conversations. We're working together at Save the Children with Josh, and we are convinced that NoviGuide will be a fantastic tool. So it had been used in Uganda, so it will be fairly easy. We have a project in Uganda under another prime to say you have used this in Uganda, let's expand to other facilities. But when you introduce something new in a country, the first thing you have to do is test it. So we work with country offices, our colleagues at Save the Children in other countries. For example, in Niger, we have a great opportunity to use any of these great innovations such as this or the Value CPAP, if you guys have heard about it. So one issue is that Niger is in French, okay? And that I don't think that for Josh would be a huge problem if you were able to do it in Spanish as well. But it is a matter of presenting it to the authorities to get the buy-in, to test it, to show them the utility. And I'm sure that we will work with Josh on that, but we're trying to get our country offices first to learn about it and get them convinced that this is worth presenting. It's just like any other innovation, I believe. And there's a lot of skepticism, I wouldn't say a lot, but some skepticism of technologies coming from the US that they're not adapted. So I see Josh nodding. So those are some of the challenges, but we're trying to get this. And I have other colleagues on the line, such as Joseph Opure and Rashid, that can speak of it as well. Thank you.
And so maybe I'll just add to that is, you know, having worked in these settings, I'm very aware that there are very limited dollars to spend on any health intervention. And I think this is one area where actually philanthropy can help because they can take away some of the risk in the initial testing. It's like, let's go and put this in 50 sites and test it, drive the cost down. That's one area. The second is the skepticism which I would say is appropriate skepticism. And that's because when I first started this work, boy, you see a lot of low quality software and one bad app ruins the bunch. And so in our case, it's like you're going against people who are doing this as hobbies, and which really just is not appropriate for medical context. And so I would say those two things. And then one last piece from just my own experience doing this is NoviGuide does so much better when we can show it. And yet many of the innovation prizes and awards are explain your work in text. It's old fashioned. And this should really be done through live demos, because there's no explaining, you could try to explain Google Maps on text and it would sound bad, because it's just not how you would explain it or show it. And so I think a lot of this is rethinking about innovations and how we share them and judge them, because I think in our case, you say something like guidelines, protocols, it's hard to envision what that's like unless you really see it.
Yeah, thank you for raising that too. This conversation has also made me think a little bit about, some of the themes the trainees are familiar with, including decolonizing global health. And I'm curious, as we talk about whose solution is it, who's determining the problem, how some of those conversations happen in other contexts when you're talking about scale, because I, well understand that you've worked really closely with the community in Uganda to start it. But now when we talk about scale, how did those conversations change and evolve?
It's a great question, and it's something we definitely think about. For me, one of the highest compliments you can give someone is designing for them. I really believe that, because you're paying attention to every single thing they're telling you, even down to the color and the font. So I think part of it is just the orientation from service delivery to tool design, I think is just a more modern approach. But the next part is you need this to be implemented locally with no travel. I'm become convinced of that during COVID, is that this needs to be Ugandan midwives training Ugandan midwives, and we simply send the technology and provide the back-end support. And we need to transfer as much knowledge, especially around the implementation, as possible. At the same time, there is no reason for a country to reinvent Zoom. There's a reason we use Zoom and not UCSF's conference software. And it's because of the efficiencies when a group can develop expertise. And so I believe that we should be developing this expertise and in certain companies and in certain groups. To put it another way, when we go to build a new pathway, we're pulling from pre-assembled parts, and that lowers the cost dramatically. And so I don't think people should just go and make their own of every single thing. And so you find the balance there. And again, I think a lot of this is design, listening to the people who are going to ultimately use your solution.
Excellent. Well, thank you for your time, for your work, to go on with the food analogies you were sharing to show us how the sausage is being made.
Yeah,
so
right.
Really appreciate all of it. I imagine if folks have additional questions, you'd be receptive to receiving them.
I was telling a colleague, this is where I found so many great volunteers, is through this lecture series. And so we've had the pleasure of having many UCSF residents and actually maybe some fellows coming on as volunteers to Global Strategies for their work. And so I'm always open to hearing from people, especially the trainees.
Thank you, really appreciate that. I've repasted the evaluation link in below. If folks can fill it out, that'd be great to give Josh some feedback in writing. We look forward to continuing the conversation. And I'll just highlight on Thursday, September 2nd, as Josh alluded to, his colleague, Dr. Muhindo, will be presenting as part of this series too. So feel free to check that out as well. All right, everybody, have a great day.
All right, thanks, Zoe.